Welcome back to Emergency Chaos, where we provide tips and tricks to help you become the best ER nurse you can be. As a new ER nurse, there are going to be a lot of conditions you're going to have to get a solid understanding of and eventually master. So, to help, we're going to review some of the most common emergency conditions that you are going to encounter. These are going to be strokes, hyperkalemia. We're going to go over RSI meds and what to do post RSI SVT, bradycardia, ventricular fibrillation, and congestive heart failure. So let's get to it. For strokes, some of the most important things when you get a stroke patient, you need to get an accurate weight and a glucose. The weight is because if it ends up being an ischemic stroke, the dosing for TNK or TPA, whatever your facility uses, is going to be weight based. So you want to make sure that you have an accurate weight so that when you calculate the dose for the medication, that it's the right dose. If you end up giving TNK or TPA, just know that it is a two nurse verification. So you should be doing the math with two nurses. You should also early on obtain a glucose level because we want to make sure that the patient is not hypoglycemic, and that's what's creating these symptoms. And we don't want it to be, we don't want the hypoglycemia to be confused with a stroke. So we want to check the glucose early on so that we can address it and assess for improvement in symptoms. For strokes, it's also very important to get a last seen normal. When did these symptoms start? This is because the window for thrombolytics is 4.5 hours from onset of symptoms, and the window for a thrombectomy is 24 hours from symptom onset. Other important things for strokes are going to be getting a good set of vital signs early on and a rapid neural assessment, and then a more detailed NIH. Vitals are important because if your patient's super hypertensive and they end up getting TNK, you need to give medications before the TNK to help bring the blood pressure down so that it decreases the risk of it turning into a hemorrhagic bleed at some point. With a rapid assessment, you're looking for facial asymmetry, you're looking for numbness in the face, you're looking for drifts, you're looking for asymmetry of the grips. The same thing for the lower extremities. Is there numbness on one side, not on the other? Can they keep the leg up with, as far as like, do they have drifts, pedal flexion, extension? How is their ability to speak? Are they slurring? So that's a quick fast assessment you can do. Are they slurring? Facial asymmetry, numbness to either side of the body, and it's like going down all the way. And is it weaker, and are there drifts? After this, one of the most other important things is going to get a head CT. The head CT is going to help us figure out if it is ischemic versus hemorrhagic, right? If the head CT will immediately you can see if it's hemorrhagic. Again, if it's a hemorrhagic stroke, you are not going to be giving thrombolytics because that's going to make everything worse, right? But if it's ruled out that it's not a hemorrhagic stroke, the providers may go down the ischemic route. And if the patient is within the 4.5 hour window of lasting normal and there are no contraindications, the providers may choose to administer TNK or TPA. And that is where having a good weight comes in. That is where having a good set of vital signs comes in. Because if the patient is hypertensive and the providers want to give TNK, hypertensive 220 over 140, they are going to have to give something for the blood pressure to bring it down first and then give the medication. Common agents used are going to be labetalol pushes. Just keep an eye on the heart rate. If the heart rate is low, you shouldn't be giving it because it may lower it. If an infusion is needed, they may end up doing something like carding, but typically pushes of labetalol end up being enough to be able to administer the TNK. And afterwards, of course, the patient turns into a one-to-one because you have to keep a close eye on their progression. Are they getting better? You're doing neural assessments Q15 minutes, and if something gets worse, there's a sudden change in mentation for the worse, you have to go back to CT to get another head CT to make sure that there's no new head bleed. Now, if it's hemorrhagic, they're going to call neurosurgery, the doctors will, so they can come down and help assess and figure out what the plan for this. One of the more important things are going to be BP control for hemorrhagic strokes. You are going to want the BP around less than 140 systolic, just to make sure that we're not increasing the pressure with a high BP inside the head and making the bleed worse. So that's why they end up bringing the blood pressure goal as less than 140 SBP. Now, moving on, let's talk about hyperkalemia. So hyperkalemia is deadly because the increase in potassium irritates the heart, and that can lead to a deadly arrhythmia. And so the most important things for treatment are going to be calcium gluconate, dextrose and insulin, sodium bicarbonate, albuterol, Lasix, Kayexalate, and hemodialysis if necessary. The main first one that you should be giving is calcium gluconate. Typically, it's 1 gram. They can do more, but typically you're going to be administering that first, and it's going to be over 10-15 minutes. This is because calcium gluconate stabilizes the cardiac membrane. So it starts working almost immediately, and that gives you time so you can start preparing the other interventions, right? So what I do, I pop the IV in, get all that going, and give the calcium gluconate first. While that's going, then I'll check a sugar to make sure that that it's going to be okay for the insulin. And then I'm getting the insulin ready, the dextrose ready. I give the dextrose first, and then I give the insulin. Then I'm also getting the sodium bicarbonate ready. Again, the insulin is because the insulin drives potassium into the cell, decreasing the serum of potassium. Sodium bicarbonate is a buffer, right? So it's going to decrease the acidosis. And when you have alkalosis, that drives potassium into cells. Albuterol again does the same thing. Lasix is a potassium wasting diuretic. If they're a dialysis patient and they don't make urine, then the Lasix isn't going to do anything. But if they do make a little urine, the Lasix can help excrete potassium in the urine. Pioxalate is going to be one of those medications. It's the one that they drink because it binds potassium in the GI tract. But don't prioritize this. It doesn't start working till 6-8 hours. So you want to prioritize the other medications first, since they start working faster, and then you get to the Kayexalate after you do the other stuff. And if your patient is super, super, super unstable, then dialysis is going to be done to remove the potassium more definitively. Now, moving into just rapid sequence intubation, some of the most important things here that you should do, you should sedate before you paralyze. So the common sedatives that we use in the ER are going to be etomidate and ketamine for rapid sequence intubation, right? Etomidate is overall just a stable medication that doesn't cause instability. So you're going to see it commonly used. Another one that can be used is ketamine. Ketamine is often used for your respiratory patients, like asthma patients, if they have to get intubated, because ketamine helps bronchodilate, and it can give you a little bump in blood pressure and heart rate. Again, etomidate is the most hemodynamically stable, but ketamine can also be used for these respiratory patients. And then you sedate first, etomidate, and then you paralyze. The common paralytics that we use are succinylcholine and rocuronium. The big differences is how fast they start working and how long they last. So the main one that's commonly used is going to be succinylcholine. It starts working faster and it only lasts between 10 to 20 minutes, while rocuronium takes a little longer to start working. Doesn't take too much longer, but just a little longer, like a minute or so, but it does last up to an hour. That's a big difference to keep in mind, because if the intubation is unsuccessful and rocuronium is in the body for around an hour, then that can lead to complications because the patient's going to be paralyzed, and you're going to have to be very vigilant with their airway and be just on it. So just be aware of that. The main thing that you need to know about succinylcholine is it does come with a side effect of hyperkalemia. So you will avoid it with burn patients, with crush patients, with rhabdomyolysis patients, any patients that are susceptible to hyperkalemia. Moving on. So after the patient gets intubated, you are going to have to most likely put your patient on some type of sedation, right? Being intubated, having all these tubes, all of this is very painful. So you want something to sedate them, and then something for pain. A common sedative is propofol, and there's also Versed. There's also Precedex and other medications, but these are the two common ones that I've seen: propofol, Versed. Main thing with propofol is that it can cause hypotension. So just after you start it, make sure that you're recycling your blood pressure often, just to gauge how your patient reacts. The good thing with propofol is that if you turn it off, it wears off in 10-15 minutes, so you can get a good neuro assessment. The thing with Versed is that it's a little more stable than propofol. It doesn't have the same giant effects on the blood pressure, but it does last longer in the body when you turn it off, for the patient, for it to wear off and the patient to come back to normal. A common pain medication used for these patients that are intubated is going to be fentanyl. And then afterwards, you also want to keep in mind that you need to put it on soft restraints, a Foley catheter, an OG tube, and have plenty of IV since you're going to be doing a lot of medication, a lot of drips. Of course, soft restraints are generally done because you don't want your patient to accidentally wake up. You're not in the room and then pull out their tube. Of course, you just need to have an order for this. The same thing for the Foley and for the NG tube. Now, let's talk about SVT. So, SVT, patients coming in, they're super tachycardic and they're unstable, hypotensive, pale, maybe altered. The main thing is going to be, are they stable or unstable? Right? If they're unstable, it's going to be a lot of those things: hypotension, altered, pale, diaphoretic. If they're stable, they're still talking to you, BP still holding on, right? And if they're stable, you're able to do the vagal maneuvers. That includes bearing down, that includes blowing on a syringe, that includes maybe a pack of ice to the forehead or the face. And if you are doing the vagal maneuvers as far as like them pushing or blowing on an empty syringe, it has worked for me where you lift the legs up at the same time that they're blowing, and that has converted some patients for me. But otherwise, if they're unstable, and if the vagal maneuvers don't work for the stable patients, then you can move on to the adenosine. Now, if they're unstable, you need to move immediately into cardioversion, putting the pads on, sandwich in front of the chest and in the back, and just sandwiching the pads together and getting cardioversion going. Now, let's talk about bradycardia. Again, the same thing, right? Are they unstable or are they stable? Because if they're unstable, you're going to be jumping to a lot of the more um, important interventions immediately. But the main things are going to be getting an ECG, right? Are they bradycardia because they have a right-sided MI, or is it a third degree heart block, or is there something else that's going on, right? If there's a third degree heart block, you're most likely going to jump just into pacing the patient because atropine doesn't really work. But if it's not a third degree, um, or it's like a sinus bradycardia, the main first medication that it's going to be given is going to be atropine. Remember, it's 1 milligram, and you can go up to a max of 3 milligrams. If this doesn't work, you can put them on an epinephrine drip or a dopamine drip. And just also keep in mind reversal agents. For example, if the patient overdose on calcium channel blockers or if they overdose on beta blockers, just keep those reversal agents in mind for that. But again, like with SVT and with bradycardia and with a lot of the rhythms, are they stable or unstable? By the way, if you're finding this helpful and want to save time and energy with mastering the chaos of the ER, you can check out our book and course. They are packed with everything you need, including foundational material, quizzes, and practical tips to help you feel confident and prepared in the ER. The course comes with video lessons, scenarios, charting fundamentals, practice tests, and our book downloads as well. You can find the links in the pinned comment and description below. Thank you. Now let's move on to ventricular fibrillation. The most important thing with ventricular fibrillation is going to be immediate defibrillation. That's going to be the main thing that helps them go from ventricular fibrillation back to a rhythm that is actually going to lead to a pulse. Besides the immediate defibrillation, we have CPR, epinephrine every 3 to 5 minutes, and then amiodarone because it's an antiarrhythmic medication. Now let's talk about congestive heart failure. The main things with congestive heart failure that you need to keep in mind, especially when it comes to the workup and ECG, just to help rule out STEMIs and STEMIs, to help rule out any arrhythmias that may be causing congestive heart failure. For example, if a patient's been in AFib for a long, long time and they're just been getting worse and worse, that can lead them to develop heart failure, right? So an ECG, a BNP to check how bad and how severe it is, and a chest X-ray can help evaluate for pulmonary edema. As for the treatments, the most important one's going to be BiPAP, nitroglycerin, and Lasix. Keep in mind, remember that congestive heart failure, all their troubles come from just fluid overload, and that fluid overload in the lungs as well. So the BiPAP will help oxygenate and ventilate, pushing the air in, pushing that oxygen in, and it's going to help open alveoli because it's going to push that fluid out back into the pulmonary vascular and into the body. The nitroglycerin helps decrease preload and decrease pulmonary congestion, and then the Lasix helps get rid of that extra fluid in the body and excreting it, right? The main ones you need to prioritize. Let's say that the nitroglycerin's order and the Lasix is ordered. I would prioritize giving them the nitroglycerin first because that's going to lead to the most improvement in symptoms. and then giving the Lasix almost immediately afterwards. And of course, keep an eye on your patient, monitor them. The contraindications for BiPAP is just if the patient's altered. If they can't remove the mask on their own, they shouldn't be on BiPAP, because if they start throwing up, vomiting, and you're not paying attention, they can just aspirate and that leads to a whole plethora of other complications. So just be mindful, be vigilant, keep these critical patients within view, and constantly assess them, especially the nitroglycerin. Constantly reassess the blood pressure. Even though most of these patients come in hypertensive, some of them react very fast with nitroglycerin, and it drops their blood pressure almost immediately. And some of the most important things for just nursing is when the patients come in, get them on the monitor, place an IV, go down the ABCs, and address any abnormalities. If they're hypotensive, place an IV, get ready to address it with either fluids, maybe vasopressors, maybe blood products, depending on what they're there for. If they're hypoxic, get them on oxygen. When it comes to placing an IV, just make sure you put a good tourniquet on, put two if you need to, let the arm hang go, and give good tabs to get the veins to pop out. Remember, you have the good AC veins, you have the back of the hand, you have the thumb wrist vein. You also have that medic vein that's behind the forearm, and just get them on the monitor so you can get a full set of vital signs. Again, thank you for watching today. Hopefully you learned something, and hopefully we helped you become the best ER nurse you can be with these tips and tricks. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.